My name is Winston. I'm the current Vice President of the Florida Society of Clinical Oncology. Welcome to this session of Living with Prostate Cancer webinar today. Thank you for attending. And just to mention that FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is otherwise known as the voice of oncology in Florida, and many of these individuals presenting and participating in this webinar are members of FLASCO and very active care, health caregivers in oncology, social work, radiation oncology, radiology, and many other specialties that support the cancer patient in their journey. I will be serving as the moderator for today's webinar, and our topic today is living with prostate cancer. As everyone knows, prostate cancer is a very common disease in men and is the second most common cancer, about 200,000 a year. But unfortunately, a sober reminder to all of us, about 27,000 of those patients with prostate cancer still don't make it. That's why there's a need for education, a need to share expertise so that patients, caregivers, and the general public is aware of the challenges in the treatment of cancer and hopefully maybe early screening of cancer. Today's talk will involve surgery, radiation, imaging innovation, treatment options, and above all, and most important, the financial and supportive assistance that can be given to prostate cancer patients. We also need to remind ourselves that advocacy is important. By the way, this talk will be given online instead of live by Dr. Michael Diaz, our former president of FLASCO. Before we begin the presentation, we would like to thank Blue Earth Diagnostics for sponsoring this webinar and making it possible for us to share this important information. I like to let everyone know that this is being recorded so that those who are not able to attend can view it at a later time. Please note that your lines will be muted for the duration of the webinar, and towards the end of the meeting, we will host a question and answer, and we encourage you to submit more questions so that we can have a very interactive meeting for today. I am honored to introduce our amazing group of panelists, and I will briefly introduce them, but please read their bios, above all, impressive bios for this meeting that I emailed to you. Now I'd like to introduce our panelists. Dr. Raymond Pack, Chair of Urology, Mayo Clinic, Florida. He has expertise in minimally invasive laparoscopic, robotic, endoscopic surgery. Ray, welcome. We have Dr. Katherine Tzou, radiation oncologist at Mayo Clinic, and one of our most distinguished prostate radiation oncologists who works hard every day taking care of our patients and collaborating with me in the care of all our patients at Mayo. Katherine? We have Ephraim Parent. He's assistant professor of radiology, dual boarded in radiology and nuclear medicine. He's an advocate for patients. He gives education talks around the country in nuclear medicine, and he's in the cutting edge of looking at ways to enhance imaging so that we can take better care of our prostate cancer patients. Ephraim?
Hello.
Good. And we have Makeyev, board certified medical oncologist. He's part of Genesis Care here in Jacksonville, Florida. One of our able oncologists and distinguished oncologists. He used to be assistant professor at the VA in Bronx in New York. And he will be here to share with us the oncologic treatments of prostate cancer. And most importantly, we have Michelle Walsh. She's sorry. Go ahead, Jan. And we have Michelle Walsh, who's a licensed clinical social worker at Mayo Clinic, and she will share with us the most important challenge in taking care of the patient, the financial, emotional, and psychological challenges. With all the words that I said, I hope I don't make a speech, but I thank you all for your insight. And Dr. Pak, welcome, and share your thoughts about the surgical challenges in the treatment of the patient. I like to remind all the attendees that if your comments spark any new questions, comments you like to share, you're welcome to type it in the chat box, and I'll read as many as I can at the end of this session. Dr. Pak.
Thank you, Dr. Tan. Good evening, everyone. Dr. Tan, thank you for the opportunity to speak tonight to the group, and thank you to the meeting organizers. Nice to meet everybody, and nice to be on the panel with all my important colleagues who are involved in the treatment of prostate cancer on a day-to-day basis. So today I'm going to talk to the group about novel surgical approaches to treating prostate cancer. I'll talk about some of the current therapies, and certainly we'll discuss briefly some of the future potential therapies that Mayo Clinic will be offering in the very near future. Let me go ahead and share my slide deck with everybody here. And let's see. Share screen. Okay, and okay, can everyone see my slides now?
Yes.
Great.
Yes.
Perfect. Okay. All right. And thank you for the kind introduction, Dr. Tan. So today I'll be talking about surgical options for the treatment of prostate cancer. And oftentimes as a urologist, we will make the initial diagnosis of prostate cancer, since we'll be screening our patients with PSA and performing biopsies. Oftentimes in the journey of patients with prostate cancer, we're the front line. So when we typically make the diagnosis, I will work with my colleagues such as Dr. Tzou in radiation oncology to talk about radiation options for our patients, but also focus on surgical options as well for localized cancers. Later in a patient's journey, sometimes they may have recurrent cancers that may need to be treated with radiation or with chemotherapy or with surgery. So surgery can be offered up front, can be offered after a recurrent cancer, after primary radiation treatments or other treatments. And then sometimes with some of the novel imaging that Dr. Parent will present, we can even offer some forms of therapy focused on removing lymph nodes for recurrent prostate cancer that only show up in suspicious lymph nodes. But today, the bread and butter, which I'll be focusing our discussion on, is the innovation or the role of robotic prostatectomy. But as you can see here, these are currently some of the options we offer for prostate cancer at Mayo Clinic. For when it comes to removal of the prostate, we do still offer open retropubic prostatectomy and robotic prostatectomy, of course. Open transperineal prostatectomy is a unique approach that's done through the perineum, not commonly done around the country. Prostate ablation is another form of surgical treatment for prostate cancer that doesn't involve removing the prostate, and it basically involves applying some form of energy to treat the prostate itself, destroying normal tissue, but also cancerous tissue. Ablation is kind of an umbrella term to cover any techniques that fall into this category. So you can use cryo, like liquid nitrogen, to freeze a portion of the prostate or the entire prostate. We call that cryoablation. You can use lasers, focal laser ablation, to focally ablate tumors in the prostate, FLA for short, and that's usually performed by our radiology colleagues. A more popular option these days is high-intensity focused ultrasound. And high-intensity focused ultrasound, or known as HIFU for short, has been around in Europe for many years and has been approved to treat tumors in solid organs. So it's been used in liver cancer. When it comes to prostate cancer, HIFU has traditionally been delivered transrectally. And so it's using high-intensity focused ultrasound, essentially using ultrasound energy to heat the tissue to the point where the tissue breaks down and is destroyed. And so again, that will destroy normal and cancerous tissue. When applied in a focused manner, it will destroy only in the target beam range. So now at Mayo Clinic, we are looking at HIFU, but delivered in a different way, not through the rectal wall, but through the urethra, which appears to be a better delivery method for HIFU. So we're currently investigating the role of HIFU. And then there's also another technology called irreversible electroporation, or IRE for short. And that's basically using electrical conductivity and denaturing or destroying cellular tumors and normal tissue by affecting the pores and the electrical pathways for cells. That is kind of come and gone. It's used for other solid tumors, but it also has been applied in specific cases for prostate cancer, but certainly we do not have a lot of experience. But everything highlighted here in yellow is something that we currently offer at Mayo Clinic. So just to give you a little background on the prostate, a lot of people may not be aware, but the prostate is deeply embedded in the pelvis. We sometimes joke as surgeons that it's probably wasn't meant to be removed because it's in such a dangerous location. You can imagine the male pelvis is a very tight space, and there are a lot of critical structures around the prostate, such as the bladder, the rectum, the urethra, and really the pelvic floor. And a lot of critical structures can be adversely affected by our treatments. Specifically with surgery, you may be surprised to learn that it wasn't until 1982 that anatomists and surgeons figured out where the sphincter, where the nerves for erections are, and where the blood supply to the prostate comes from, and how to safely remove the prostate. This work was attributed to Dr. Patrick Walsh at Johns Hopkins. And so after years of dissecting cadaveric male specimens and studying the anatomy, he published a seminal paper on how to remove the prostate without major blood loss, without causing major incontinence and major impotence. So Dr. Walsh is a luminary in our field and a pioneer. And in fact, he writes, he's an author of a very useful prostate cancer guidebook for a lot of patients who have been diagnosed with prostate cancer, would like to learn more about the treatments. So he has a very comprehensive reference book that I always recommend my patients purchase or take a look at, because it's it's a good reference guide and a guide for patients, going through the journey of treating prostate cancer. But a lot of his work was important in allowing us to be where we are today. And so currently today, our techniques of removing the prostate are still based on Dr. Walsh's principles of the Walsh nerve-sparing radical prostatectomy when it's appropriate. So what are the side effects of prostatectomy? So prostatectomy is most notoriously associated with incontinence, losing bladder control, and erectile dysfunction, losing sexual function. What also can be lost with removal of prostate from a practical standpoint is the fact that, when you remove the prostate, you will lose your fertility as a male. So the prostate's really only function is to provide the semen, the vehicle for sperm to travel to have children, and also provides nutrition to the sperm. So without the prostate, men cannot father children through natural ways. But the practical side effects of removing the prostate can result in incontinence, erectile dysfunction. There can also be scar tissue that can form, and also sometimes secondary deformities of the penis can arise from the surgery itself. So, historically, the rates of incontinence and erectile dysfunction have been what drove a lot of patients away from considering surgery, especially younger men. If you can imagine being a 40-year-old man with newly diagnosed prostate cancer and facing the prospect of being infertile, incontinent, and impotent, you can imagine that men will start to look at other options. So I do not blame my patients when they want to see what the option landscapes are for the treatment of prostate cancer, because my offerings to treat prostate cancers can sometimes be the most frightening for patients. So, as a surgeon, I've experienced the evolution of our field, and I apologize if the pictures are too graphic, but I wanted to illustrate how our surgical field has evolved from traditionally an open operation. On the far left of the screen here, you'll see a traditional 7-inch, 8-inch incision that was required for an open radical retropubic prostatectomy. In the middle picture here, this is where we currently are with multi-port robotic surgery. And then on the right here, you can actually see a gentleman who has just one hole, and we call that single port robotic surgery. So that's where we are today. So our field surgically has evolved from a big open operation to now mostly a robotics procedure. And in fact, what used to involve a 3 to 5 night stay in the hospital now is a same day operation, if you can believe that. So part of the reason why we're able to be less invasive and causing less pain for our patients and maybe better outcomes for our patients is because of this tool here that you can see on the screen. This is the first robotic system that was used for treatment of prostate cancer, and this is the intuitive surgical device known as Da Vinci. Intuitive Surgical was a company that was one of the first to launch a robotics platform for surgery. This company nearly went bankrupt if it were not for prostate cancer and prostate cancer patients. So this company created the system actually to help with open heart surgery. And you can imagine opening the chest to repair the heart valves or the vessels was a very difficult incision to recover from. So the company thought that would be the best way to enter the market. Well, they ended up with a device looking for a procedure because a lot of cardiac surgeons didn't embrace this technology. So the company almost went bankrupt, but then it was given in the hands of some urologists who were struggling, trying to innovate in the minimally invasive radical prostatectomy space. Going from open to laparoscopic was a very difficult feat for urologists because the laparoscopy did not allow us to be able to sew the bladder and urethra back together after removal, the prostate efficiently. So the learning curve was tremendous. So when this company came around, some urologists who were very innovative in our field decided to try it out. And so the company always says they aimed for the heart and landed on the prostate. So the company was basically taken out of bankruptcy because of the role of the robot for treating prostate cancer. So when I was a resident, when this company came out, I was clamoring for Mayo Clinic to purchase this system because I was eager to learn and adopt this new technology. But there were a lot of skeptics out there in the very beginning of the field. You can imagine Dr. Walsh, who made his career on open radical retropubic prostatectomy, was the loudest antagonist for the robot. He felt that the robot was experimental, was dangerous. You couldn't feel tissue, so you lost that sensation. So the robot company initially had a very big uphill battle. However, they were also very smart in that they started to market their technology towards patients, and patients quickly embraced it. When you attached the robot to any kind of surgical procedure, all of a sudden it became a surgery that was futuristic, scientific, maybe even painless, and maybe even no complications. So clearly our prostate cancer patients helped this company survive. And the concept I always like to share with everyone is that this is an example of crossing the chasm. It's a concept presented by Jeffrey Moore, but this is really a curve showing the adoption of technology in our lives. Now, you can imagine, I'm sure everybody here in different points of their lives have experienced technologies that have come and go, and that it may have fallen to the chasm. Things like VHS versus Betamax. Betamax clearly didn't make it and probably fell down the chasm. Things like the 3D television, which was, super popular for a while, and then that kind of faded away. BlackBerry and iPhone. So the list goes on and on. But this is a perfect example of a company with a technology that almost didn't make it. There were early adopters, but the company didn't quite take off as they anticipated. But again, like I said before, because of prostate cancer, the company was able to come out of the chasm, and really we're on the far right of this curve now. Robotic surgery is here to stay. And in fact, Intuitive Surgical is one company, and they still are the only major surgical platform that's robotics right now. But quickly in the next 5 to 10 years, the landscape's going to change with key patents expiring. There are at least 5 companies that are waiting to release their robot to the world of patients and surgeons. So when you look at the statistics right now with robotic surgery, annually around the world, there are 1 million surgeries performed using the robot. There are about 6,000 systems installed worldwide. I mean, this robot has been installed to the far reaches of Eastern Europe and China and Russia. So, it's all over the world. And the market is, approaching $7 billion this year. So it's a very large market. And any investors on the call today, if you just type in ISRG on your stock ticker symbol, you'll see that the curve for the company has grown just like the number of systems installed around the country. It's been an exponential growth. And I think the company will be here and stay for a long time. So what have been the goals of robotic surgery? Why is robotic surgery why has it impacted our field so much and made our surgery so much better? Well, it really helps to correct some of our human inadequacies. Hand tremor is filtered out. Visualization is improved no matter how bad your eyes are. And the suturing really is tremendously better. The robot suturing far outperforms any laparoscopic or hand suturing that we can perform because of all the benefits of the robotic system. And this does lead to better outcomes for our patients, decreased pain and suffering, decreased length of stay, and of course, more importantly, improving results for our patients. So this is probably the first time in the field of surgical medicine where a procedure or technology was adopted before the results came out. Like, as I said before, the company was very smart. They started marketing to patients. Patients started pushing for this, even before doctors were convinced, and even before clinical data showed that the robot was any good. Patients started pushing for it. The company supported that. And so this was truly a case where patients, the needs of the patients were met because of demand, not because of the clinical evidence. But however, since that time, luckily, the evidence has come out that the robot system is better, and I'll show that a little later. But many of you may not know that the robot is a platform. It's completely controlled by the surgeon. It's not autonomous, meaning it doesn't do anything on its own. The biggest benefit from a visual standpoint, as I mentioned, is 3D vision. So, right now we can see in 3D. So we have depth perception, we have high definition imaging, and it's magnified. So we can see much better than the human eyes or even eyes with loops, surgical loops. It's user controlled, like I said, and our movements are reproduced inside the body with these small robotic instruments. And these are miniaturized instruments, much smaller than a hand, maybe about the size of a pen tip. And it allows us to preserve the dexterity of our hands. As I mentioned before, sewing laparoscopically is a very difficult task. It takes many hours of practice, probably tens of thousands of hours to be able to perfect that technique. Well, the robot really makes it much easier. And so that's why surgeons have adopted this technology, because it allows us to be minimally invasive, but also maximally effective. And as I mentioned before, the clinical data eventually came out that showed that robotic surgeries led to much, much less blood loss, much clear improvement in recovery in terms of speed of recovery and pain and suffering for patients. Cancer control in the correct hands, a robot is a tool. So in the correct hands, cancer control can be optimized. And the same thing I'll say for continence and potency. Continence meaning preserving the ability to keep the bladder from leaking, and potency being able to do nerve sparing to preserve a man's erections. Now, those last two haven't really panned out in the clinical evidence to be a slam dunk, partly because the outcomes are potentially washed out by surgeons who dabble in this procedure. The evidence has been shown with open and robotic surgery that if you have surgery with an experienced surgeon, and that's the key, an experienced surgeon, no matter if it's open or robotic, your outcomes for continence and potency will be optimized. So I will qualify that saying that robotic surgery is better across the board. And now we've innovated to the point where we have single port robotic surgery. And this is the newest system that we've purchased in 2018. Mayo Clinic was one of the first hospitals in the country to use this machine in patients for prostate cancer. And so we've gone from multi-port now to single port surgery. And I'll just let this video play. Hopefully you can continue to hear me talking. But you can see that the single port robotic surgery allows us to put all the instruments and camera through one small incision to work in very tight, narrow spaces, such as the human pelvis. So we currently have the system installed at Mayo Clinic at essentially all 3 hospitals in our system. And I personally performed about 30 of these procedures already. And my total experience so far has mainly been the multi-port robotic, over 2,000 multi-port robotic systems. Okay, so that's all I have on the video, so I'll just keep going here. But that you can see the surgeon console on the right here on the slide, the robotic system in the center, and then there's the brains of the computer or the robot, which houses the CPU and the hardware on the left side. But this is essentially a very expensive platform. It's over $2 million, and Mayo Clinic has committed to our robotic surgery program and made the investments. We actually have 5 robotic surgery platforms, one of these, but 5 total, including 4 multi-port robotic systems. I think future directions, you'll see robotics becoming smaller. You'll see them becoming flexible instrumentations. As you can see, like in this snake-like robot here. And in fact, this robot is currently available at Mayo Clinic. And this allows us to do advanced robotic bronchoscopy. But as the technology improves, you can even now adopt going from rigid instruments to flexible instruments. I think you'll be seeing in the future more incorporation of image guidance. You can see on this picture here, we have certain things we can inject in patients that can help highlight certain anatomy. And the goal would be to highlight cancer versus normal tissue, or to help highlight worrisome lymph nodes to remove. And then, if you can imagine, we also now can also use augmented reality using computer-generated images to onlay on top of our surgical field, and these images would be generated from 3-dimensional advanced imaging, such as MRIs of the prostate and some of the things that Dr. Parent will talk about. But eventually, the goal will be to have real-time images overlaid on top of the surgical field to allow us to perform safer and better surgeries. And further down the road, we might be incorporating artificial intelligence into what we do on a day-to-day basis. So the one thing I did want to mention before I end my talk today is I mentioned the ablation techniques and HIFU. So to end this talk, I wanted to kind of close with the newest kid on the block, or the newest technology would be the HIFU, as I mentioned. But Mayo Clinic is really focused on delivering this HIFU through the transurethral approach. And this is being spearheaded by my colleague, Dr. Chandler Dora, who's done about 30 patients, completed about 30 cases now, and he's reporting some of the data, and it looks very promising. And this is a good alternative for patients who don't feel that surgical removal of the prostate or radiation is attractive to them. However, this procedure is not for everybody, but in the right situation, this might be another option that's good for patients. And that's something we do offer currently as a surgical option for the treatment of prostate cancer. So that's all I have for the group today, and I'm happy to take any questions now or during the panel. I think for time's sake, we probably should keep going, and be happy to answer any questions during the panel. Thank you.
Thank you, Dr. Pak. We will turn over the session to Dr. Tzou, who will talk with us the what and the how of radiation.
Good evening, everyone. Let me share my screen here. Give me 1 second. Is everyone able to see my screen okay? Or my slides, I guess?
Yes.
Okay, good. Oh,
Yes.
thanks. I got the thumbs up. Sorry, I forgot you're all muted. Okay. So today, like Dr. Tan said, well, first off, thank you to Flasco and Dr. Tan for inviting me. I'm truly honored to be a part of this esteemed panel. And I always learn something new every time I hear Dr. Pack talk. So that was a great talk for me. So today what I'm going to be talking about is, like Dr. Tan said, the what and the how of radiation. So essentially the basics. There's a lot with radiation therapy, but I want to kind of highlight the main points, and I'm happy to answer any questions at the end. So we're going to talk about, first off, what is radiation therapy? Sort of this amorphous concept to a lot of people who don't have to deal with it day in and day out. What types of radiation treatment are available, the indications for radiation treatment when we use it, and most importantly, what patients can expect. So as most of us know, there's always some level of radiation around us, and that's what this electromagnetic spectrum from our grade school days showed us. There's radio waves, there's microwaves, infrared devices. With radiation therapy, we're actually using a very high voltage, deeply penetrating radiation called ionizing radiation. And basically what that means is it's this packet of energy that's produced from a source, travels through space, and then it breaks up DNA. In a nutshell, it creates these ions that break up DNA, and that's how we're effectively able to kill cells. So a common question that I get from patients is, well, how does radiation distinguish between normal and regular tumor cells? And it can't. And that's why normal cells can be affected by radiation, right? That's why patients are going to have some side effects. They are localized to the area that we treat, but we can't avoid side effects altogether, no matter how focal the therapy is designed. The difference is normal cells have the ability to repair DNA, DNA damage. So they have this DNA repair mechanism, whereas cancer cells are usually so aberrant that they typically lack these mechanisms for DNA repair. And so that's how we're able to selectively kill off those cancer cells. We render them unable to reproduce. So when they try to go and multiply and divide, they die in that moment. And that's essentially how radiation works. There are many different forms of radiation, and I'm showing you 3 of the more common ones here. So external beam radiation, which is this huge machine that kind of hovers over this nice hard CAT scanner-like table in the treatment machine, is usually the one that everyone thinks of, and the more common way that radiation therapy is administered for prostate cancer. So this is oftentimes used for definitive therapy as well as palliative therapy. So it's a big machine that uses X-rays or particles to external beam, administer radiation treatment deep inside the pelvis where the prostate is. Then there's a very localized treatment called brachytherapy that's a bit more invasive. So instead of this machine outside your body, there are actual radioactive seeds that are either permanently implanted in the prostate, or we use these hollow catheters to temporarily do what we call a radioactive seed implant, which I'll get into more details of that, but that's what brachytherapy essentially is. And then there's another type of radiation called a radioisotope, which is a radioactive material that's injected into blood vessels typically. And that is a much more broad spectrum type treatment, although targeted and typically reserved for metastatic disease. So this is another picture of external beam radiation. You see the patient laying on the table and this big machine moving around them. The radiation is produced in here and travels out through what we call the head or the gantry of the machine. And this is a better, more close-up picture where it's kind of generated in here and comes out through this head, directed at whatever area we're targeting. And this could be an accelerator. It's called an accelerator. It could produce X-rays or photons, which is the type of radiation that's more commonly used, or particles such as proton therapy. So there are different types of external beam, like I just alluded to. There's one with X-rays, which is photon therapy, and the old way of using that was sort of these, you imagine these stationary flashlights staying in the same position every time, focused right at the prostate with all the light beams convening in the same spot. That's 3D conformal radiation. There's another version called intensity modulated radiation, or IMRT, also known as VMAT treatment, where the beam is continuously moving around the patient. And if you think of it like a million different very narrow flashlight beams aimed at the same spot, with these little leaves moving in and out of the field to help block out things like bladder and rectum. So it's a very focal treatment, really conformal to the prostate subvesical area that Dr. Pack so kindly oriented us to with anatomy. And then this is a particle machine down here. So this is a linear accelerator for photons, and this is a picture of what a proton machine looks like. Similar idea, flat table, big gantry head coming up above you. It's a much bigger room, bigger machine, but otherwise same similar concept. This is a picture just showing you sort of those little leaves I was telling you about that come in and out of the radiation field in the head of the gantry. This is a view as if you're the patient laying down on the table looking up at the head. You can see these little metal leaves that move in and out to kind of conform to the patient's own anatomy. And this, I'm going to go into this next section just to give you an idea of the difference between protons and photon therapy, because that's frequently a question I get from my patients. Thankfully, Dr. Pack already went through a lot of the anatomy, so I'm just going to reorient you. This is a picture as if I'm cutting you in half, or cutting the patient in half. So the rectum is on the back side, the prostate is in pink here, in yellow is the bladder, and this blue is something called spacer, which is a gel that gets injected between the prostate and the rectum prior to treatment to help reduce radiation dose to the rectum, which I'll explain a little bit more about that a little later on. This is a picture looking at as if I'm cutting the patient like a loaf of bread, and we're at the level of the hips and the pelvis. So this is front, back, left, right, and this yellow is the bladder, pink again is the prostate, blue is that spacer gel, and brown is the rectum. So with proton therapy and with IMRT, the high dose region is fairly similar. So each of these colors represents different dose lines. So the target again is shown here in pink. The red line here is our target dose. So that's our 100% dose, which we actually want it to kind of bow out a little bit from the target, because the prostate naturally is going to have some movement with, depending on how full or empty the bladder is, or how full or empty the rectum is. So we have to account for that motion in the planning. But you can see in terms of conformality that the high dose area is very similar between IMRT, which is X-ray treatment over here, compared to proton therapy. So high dose area is very similar. Then when we start to turn on the lower dose line, so now you've got the high dose area looking very similar, but if you start to look at this dark blue on this picture and this picture, the dark blue is the 40% dose line. So that's 40% of the prescribed dose. So you can see it starts to bow out a little bit more with photon therapy, still sparing a good portion of the front of the bladder, back part of the rectum, but it's less so with the proton therapy. And then this is a picture taking you even further down on the dose chain. So now we're down to 5% of the dose. And you can see when you turn on the 5% dose, you get this sort of low dose bathing around the pelvis with the photon treatment, as opposed to proton therapy. So with IMRT, like I mentioned, the beam typically is going all the way around the patient kind of continuously. With proton therapy, they typically use these fixed beams. Our colleagues across town use 2 fixed beams going through the hips. These are pictures that I borrowed from my colleague up in Rochester, and in Rochester they use 2 beams coming through the hips and then 2 beams coming from the front. So you can see there's less of that 5% dose, which is now this dark blue / purple color. So you can see there's really no dose going to this portion of the bladder and this back portion of the rectum, but there still is some dose going, to the back half of the bladder here, whereas really the entire bladder and the entire prostate are sort of covered with that 5% dose. Now, what does that mean clinically for the patients? We don't really have a head-to-head comparison, although we do have an ongoing trial called the COMPARE trial that's going on nationally with multiple institutions, including Mayo, and is headed up by the University of Florida. But we don't have a published data on a head-to-head comparison in terms of toxicity or side effects, patient-reported side effects between protons and IMRT. What we do have is enough data to say that they're both equally effective in terms of cancer control. And we're still investigating whether or not there are particular side effects or particular groups of patients that might benefit from one or the other in terms of toxicity. But right now, the data is looking fairly similar when you're looking at the not a head-to-head comparison, but just retrospective reports of institutions that are using one or the other. So in terms of fractionation, so fractionation is meaningful to the patient. It's how many times do you have to come into the clinic, basically, for treatment. And with historically, that was over 8 to 9 weeks of daily treatment, once a day, Monday through Friday. So it was very frequent to have something like 44 treatments planned. More recently, I guess all in science, recent being in the last 5 to 10 years, we've adopted something called moderate hyperfractionation, where it's biologically a similar dose, a little higher dose per day, but we're able to break the treatment down to about 4 weeks. And then even more recently than that is ultra hypofractionation, where we're actually able to cut that treatment down to 5 treatments, but because it is such a large dose per day, it's given every other day over about a week and a half. Now, just to touch on brachytherapy a little bit, just so you have a concept of what that is, there are 2 main types that are most frequently administered across the country today. One is called low dose rate and one is called high dose rate. You don't really need to remember the names of the procedures so much as I just wanted you to understand that they exist. Sometimes we can use brachytherapy alone, which is what monotherapy means. And sometimes we use it in conjunction with that external beam therapy as a boost, particularly in patients with high risk disease. So like I said, there's 2 different types. With low dose rate or LDR brachytherapy, the nice thing about it, one of the pros of it is it's a one and done. It's sort of like a surgery where you go in, you get it done, you walk out, and you don't have to keep coming in every day for treatment, as long as that's your only treatment recommendation and you don't need external beam. So it's a one and done. It's a permanent seed implant. And it's, you're usually asleep. It's an OR procedure. You have full anesthesia. We have the guidance and the help of our urology colleagues. It's a very team approach to this procedure. The downside of LDR brachytherapy is that there are radiation safety concerns because the radioactive source will decay and deposit the dose over about a month's time. So during that time period, you really can't be close to small children or pregnant women or have anyone sitting on your lap, including pets, just because of some of the radiation safety concerns. So, pro, one and done, downside, you have about a month afterwards that you have to really be careful about interactions. Newer to the field, although now like 10, 15 years out, is something called high dose rate or HDR brachytherapy. And if you get that as a single treatment and don't need external beam, that's actually 2 implants. So this is a 2 and done. And usually they're separated by 1 to 2 weeks. If you're using it as a boost, so you're getting external beam treatment in addition to it, then it's usually a 1 and done procedure. And this is convenient in the sense that, you're still asleep, same idea. We place these needles with the guidance and help of our ultrasound and our urology colleagues. But instead of placing permanent seeds, we actually place these temporary catheters into the area just below the scrotum while you're asleep. And then those catheters get attached to this afterloading device, which is this device out here that houses the radioactive source. So if you think of these really long straws, because these are hollow catheters, when we tell it to, the radioactive seed will go out, go down this catheter, go into deposit dose in the prostate, come back out and go down the next channel, and then come back out and go down the next channel. So the dose is administered in that fashion, and you don't have to wait for a month for that all to be deposited. The other nice thing is when the patient leaves the room, there's no radiation safety concern because the needles are pulled. There's nothing that's permanently implanted in the patient. It's fairly quick to deliver, usually several minutes, and then the dose is delivered and done. And there tends to be a quicker resolution of the acute side effects with this treatment as opposed to permanent implant seeds where, you know, the radiation is depositing over a month's time. We also utilize radiation therapy, as Dr. Pack alluded to, in the post-operative setting. So in that case, you know, sometimes we're asked to provide radiation in the adjuvant setting, and sometimes in the salvage setting. So what is that? That's mumbo jumbo, right? To anyone who doesn't do this all the time. What does that mean? So in the adjuvant setting, that means you're coming to my office, your PSA is undetectable, and you're within 6 months after surgery, but your surgeon is concerned about some high-risk features that they saw in pathology. So most guys who undergo surgery, they don't need to come back to me, which is great, right? So you're one and done with that surgery, but there are certain high-risk features that can increase your risk of recurrence. And those are usually the guys that my colleagues will refer over to us just to talk about the option of adjuvant radiation and the pros and cons of it. So historically, for tumors that extended outside of the prostate, something called extracapsular extension or invasion into those seminal vesicles that Dr. Pack talked about, those were historically patients that we would treat, although now with newer data, we typically don't. Actually, we'll monitor those patients closely if their PSA is undetectable. For patients who were found to have lymph node positive disease at the time of surgery, we do usually offer treatment to those patients, even if their PSA is undetectable. And then salvage radiation is essentially what it sounds like. We're trying to salvage the cure. So those patients are patients who have a detectable and rising PSA or visible disease. So we know, or we're highly suspicious for recurrent disease or residual disease, and we're trying to salvage the cure with radiation. This is kind of what I mentioned earlier. So the current practice, at least at Mayo Clinic, is adjuvant radiation for lymph node positive disease. And then for everyone else, we closely monitor their PSA, and we typically advocate for something called early salvage radiation therapy because it decreases the risk of distant metastases and improves cancer control. The earlier we're able to intervene. So we typically recommend starting salvage treatment when the PSA is less than 0.5 to really optimize the control. And then, you know, just to touch on other options for radiation, we do use it for palliative treatment, such as for metastases, as well as in select stage 4 patients where disease has spread elsewhere in the body. If there's a low burden of metastatic disease, we will use radiation therapy definitively aimed at the prostate or the primary source of disease. So the most important part of the talk, what can patients expect and what can their caregivers expect? So typically we start with a consultation in the department so you can hear about what you're going to need and what's recommended. If hormone therapy, which I'm not really talking a lot about here since I know we have another esteemed colleague who's going to talk about systemic therapy, but if hormone therapy is also recommended with the radiation treatment, oftentimes that'll start at the time of consultation or shortly afterwards. The next step after that is placement of something called a space or gel, as well as some gold fiducial markers or gold seeds for patients who are getting definitive treatment. Then we have patients undergo a simulation so we can outline what to treat and what not to treat. And then finally, patients will undergo treatment. And this whole process, depending on how eager the patient is, how quickly it is, can take anywhere from, you know, a couple months to as short as, you know, a couple weeks. So this is that gel I was talking about, usually done at the same time, at least at Mayo Clinic, our lovely urology colleagues place this gel while the patient's asleep. between the prostate and the rectum to really help elevate that prostate away from the rectum so that we can reduce the radiation dose, which is shown really nicely in these pictures. So this is like that loaf of bread slicing at the hip level type picture where the tan piece here is the prostate, red is the target for radiation, and this sort of mauve color is the rectal wall. And you can see with the gel present, it really helps push that radiation, the high dose area, away from the rectum. So about 1 to 2 weeks after that procedure, I usually bring my patients back to our department to undergo a CT simulation. This is our CT scanner. And this is really used to create an optimal and reproducible treatment position, as well as obtain images for radiation planning. So most of my prostate guys will have a treatment mold created, which is this purplish blue device that conforms to the patient's body, and that helps us improve the accuracy and the reproducibility of treatment each day. I then will have the patients undergo a limited series MRI. It takes about 15 minutes while they're in their treatment mold, so we can see this gel better. You can see on a CT scan at the same level, there's just different levels of gray, and you can kind of see the spacer here, but it's much more clear in white on the MRI here. So it's helpful to have both images. And then we fuse them together, overlay them for treatment planning. And that's when the radiation oncologist really goes to work with outlining, you know, the target in red, the additional margin that we need to add for motion in blue. And then we also draw on things like the rectum, the bladder, the penile bulb, the hips, and any adjacent organs that we're worried about. We work with our awesome dosimetry team to create a beam arrangement that will optimize dose to the tumor while sparing dose to nearby organs. This is just another picture of a photon plan of a prostate patient here. And if it looks acceptable, then we will sign off on that plan. We then send the plan to our medical physics team for quality assurance, and they run all sorts of tests and checklists and just basically make sure that it's safe and deliverable before the patient arrives. And then from the patient perspective, so all that's going on in the background, you know, during this planning process time that we tell patients about. But from a patient perspective, when you come in for treatment each day, essentially what I'm going to ask you to do is come in with a full bladder, which means drinking about a bottle or a 16-ounce bottle of water, finishing at least 30 minutes before treatment each day. You know, give or take, everyone's body's a little bit different, but to really try to have that bladder act like a water balloon and help move other organs away from the high dose radiation area. And then if you're getting the 5-day treatment, the really high dose per day SBRT treatment, you also have to have an empty rectum. And this is a stickler of a point because I have to protect your rectum, right? So you have to do a Fleets enema 1 to 2 hours before the simulation as well as before each treatment. So that's 6 Fleets enemas. And then I usually, as an added assurance, ask you to take fiber supplements such as Metamucil 1 to 2 times a day from the time that the space or gel is placed through your last treatment. And that's just added assurance for an empty rectum. In terms of how long patients are on the treatment table, if you're getting a standard treatment, it's about 15 to 20 minutes with the beam only on for about 2 to 5 minutes of that. If you're getting the high dose SBRT treatment, the 5-day treatment, you're on the table about 25 to 30 minutes because since it is such a high dose, we take additional images before, during, and after the treatment. And then if it's a bone met or some sort of metastasis for palliative treatment, you're usually only on the table for about 10 to 15 minutes. So these amazing people in red are trained and authorized to actually touch our treatment machines. So it's often a misconception that I need to be at the machine to touch the little red button or the little green button, but you don't want me to because these people are trained and licensed to do so, and I am not. So in terms of who the patients see every single day, you'll see me once a week, you'll see them every day, and they're amazing. We have such a great team, but they really make sure that the patient is aligned perfectly. They verify the images with us before treatment starts to make sure that we agree, and then they administer the treatment as per our plan. This is an example of some of that image guidance I was telling you about. This is an X-ray taken at the time of treatment, and these tiny little white dots, Also shown here in this bigger image are the gold seed fiducial markers. So you can see that metal shows up better on an X-ray than soft tissue. And this is an image reconstructed from the CT scan taken at the time of simulation, with these little black dots being the seeds. And so basically we overlay those images at the time of treatment to make sure that when we turn the beam on, it's 100% accurate, or as 100% accurate as we can make it. So in terms of side effects, just really quickly, because I don't want to eat up time for other speakers, you know, temporarily during treatment, typically side effects from radiation don't start until about halfway through treatment, because if you think of radiation like a pill, we're cutting it up into pieces and giving you a small piece each day, and it accumulates over time. So near the end of treatment, patients may experience some temporary increase in frequency or urgency with urination or bowel movements. If they're prone to hemorrhoid flares, they may have a hemorrhoid flare. They may have an increase in number of stools, not necessarily water, but increased number, and possibly some tiredness such that they want to take a nap or go to bed a little bit early, but most patients are fairly functional throughout treatment. Less common would be something like nausea or frank watery diarrhea. Late side effects, severe side effects are fairly rare, but sometimes you'll have some intermittent urgent stools. Occasionally you may get some blood in the urine or stool from some fragile vessels that'll develop in the bladder and rectum. It's less than 5% of the time that patients need to undergo an intervention to stop that bleeding. Intermittently, you may have that hemorrhoid flare or mucus discharge or pain with urination, although most patients don't have that as a long-term persistent side effect. There's about a 10% risk of stricture, particularly urethral stricture, because of the high dose that's given in that area that might require a balloon dilation procedure. Fecal incontinence or stool incontinence, the risk of that is usually less than 0.2%, so fairly low. Risk of urinary incontinence is about 5% or less. And erectile dysfunction, if it happens, tends to present 1 to 2 years after we're done, and it occurs in about 30 to 50% of patients. So just in summary, there are many different types of radiation therapy available, and we really try to cater the recommendations to the patient's age, their risk factors, and truly what their goals of care are. Because not every prostate patient is the same, and we want to make sure that we really cater those decisions to what the patient wants. So I'm happy to answer any questions during the Q&A session, and I will pass it back over to Dr. Tan.
Thank you, Dr. Tzou, for that comprehensive lecture on radiation and side effects. With that being said, we'll call Dr. Parent, who will share with us the imaging and innovations of the prostate cancer patient. Dr. Parent.
Great. Thank you very much, Dr. Tan. Thanks, Raymond and Katherine, for your wonderful talks. I think it leads in perfectly to what I'm going to be talking about. And so for the sake of time, you know, it's really impossible to talk about all aspects of imaging and radiotherapy, targeted radiotherapy for prostate cancer. That'd be several hours, and I think everybody would fall asleep. So I wanted to concentrate on kind of our molecular imaging, which we do now, and where we're going with PSMA, which has had a lot of excitement recently with some recent trials that have taken place. Just at the beginning, I want to, well, this is my overview, and I'm going to talk about the terminology for this slide. I'm going to very briefly talk about choline and Axmin, which are kind of well-known tracers that have been used for the last 5 or 6 years, kind of throughout the nation. And now we have some PSMA agents for PET that have just been approved. And then the last thing I'm going to talk about the radiotherapeutics that we have with PSMA that have some exciting results. So the terminology, what I want to talk about. So I'm going to talk about kind of how these tracers compare to one another and what they do. And first is to talk about sensitivity, and that's really the radiopharmaceutical or the agent that you have. That's how is it able to detect all the true disease? And really, unlike kind of the local disease that Dr. Pack and Dr. Tzou talked about, you know, really now we're looking at how can we identify disease once it's gotten outside of that prostate bed and into lymph nodes and osseous and other tissues. The specificity is what we want to do to exclude all false diseases. And overall, it's this accuracy, that's that kind of combination of the sensitivity and specificity is going to tell us how good our agent is identifying disease, because that's really what we want to do. We want to let the physicians that are treating you and the patients yourself know where the disease is and how much of it is, but we also want to provide a true analysis, not a kind of overly optimistic or overly pessimistic. When I talk about radiopharmaceuticals, what that is basically these are drugs that have a radioactive isotope that's attached to them. And these are designed in a way that the body processes them, and it kind of lets the normal physiology take place to deliver it to the target tissues, which is the cancers. And all of these agents that I'm going to talk about today are radiopharmaceuticals for either diagnostic or therapeutic processes. PET stands for positron emission tomography. It's a technique that we use to evaluate these agents, has a very nice resolution, and are able to quantify to know exactly how much is going to a tissue. SPECT, I won't be talking about today, actually, as I modified this talk. That's a different technique that we use. And then the radiotheranostics, this is the difference. These are also radiopharmaceuticals, but unlike for diagnostic agents where we use the PET, these are therapy agents that we are delivering selective radiation to the tumors and the metastatic deposits. This graph has been kind of hinted at before. There's a little cartoon that had in place, but this is kind of I think a lot of people use this, and it kind of shows the kind of course that unfortunately not most, but many patients with prostate cancer will undergo if it's not effectively resected at the beginning. What'll happen is they'll get diagnosed with prostate cancer, and that's kind of at this point, and they'll then have the definitive therapy, including surgical resection, radiation therapy, brachytherapy, and then it'll drop down to a nadir. And that may last a long period of time. It's individualized depending on the Gleason score and everything else. But eventually it's going to start going up if we have disease that didn't get completely taken out. And that's what we call this biochemical recurrence. And I'll define it on my next slide. And this is the point where imaging really starts having a role. Before that, we've done MRIs. And again, for the sake of time, I'm not talking about MRI. That is a critical modality that basically everybody with prostate cancer effectively has to kind of identify where the disease is and local spread. But now at this point, we're going to go, where is it outside of the body? Is it in lymph nodes? Is it other tissues? And so that's really kind of what we're looking at now. And there may be at this point salvage radiation therapy. It's a applicable androgen therapy in terms of deprivation therapy. And that will usually then drop the PSA, which is this kind of marker of how much disease is going on. And when it starts coming up again, this is where it starts becoming turned as castrate-resistant prostate cancer, because we now have cancer. It's resistant to the hormonal therapies that are going on. And this is where you start looking into chemotherapies and immunotherapies and things like this. And this is really where our radiotherapeutics start coming into the milieu as well, into the trials and how we can approach these things. And I'm not going to get into the medical therapies right now. It's just kind of to overlay the progression that we see. So most agents up to this point, when we've been looking for spread of prostate cancer, we're kind of been defined by biochemical recurrent disease. And this is how the FDA has defined when we can start doing these, because as with most things in medicine, they have their say in it. So biochemical recurrence is there's several definitions, but the most common one is the Phoenix definition. And that's where once you've had this definitive therapy and you are testing this PSA levels, once it rises twice, that's defined as biochemical recurrence. And that's when we can start looking to see where the disease that we're looking for. The poor lesion identification is pre-definitive therapy, meaning inability to identify where all the disease is before the surgery, before the radiation therapy, is likely a contributor to the high biochemical failure rates that a lot of patients with prostate cancer have. And traditionally, it's been done with conventional imaging. What do I mean by that? CT is the big one for staging. And really, we know that this is suboptimal at this point. And I would say it's not really standard of care anymore. There might be some places that are still doing it, but I think most places are doing some kind of molecular imaging to be able to identify where there's spread of disease. And right now, there's a lot of radiopharmaceuticals out there, and I'm going to talk about some of the main ones. And again, I'm going to concentrate on the PSMA because that has kind of been the most recent agents that have been approved, and there's a lot of interest in them. I'm going to start, however, talking about choline. So this is an agent that we use at Mayo Clinic. We've been using this for about a decade, and it's been widely used to detect local recurrent prostate cancer as well as metastatic prostate cancer, either in lymph nodes, bony disease, solid organ tissues. And again, this is initially approved for use in biochemical recurrent prostate cancer. So it's not, when you first get diagnosed with prostate cancer, you are typically not going to have a choline or an Axemin or PSMA studies. This can be changing over time because they're reevaluating this, but traditionally these agents have been used to look for that recurrent disease status. This is a picture I'm showing here of a man with prostate cancer, previously definitive radiation therapy, comes back with rising PSA, short doubling time, and we see a single lymph node in this right external lymph node chain, right operator lymph node chain, where I'm pointing to with the arrows, that was found to be recurrent disease. This is a slide that I show our residents and I go, you don't need to memorize all this, but the overall process of this is kind of complicated. Ultimately, what's happening is that choline is a precursor for the membrane, the outer shell of these prostate cancer cells. And as they're dividing, they grow this a lot. So we're able to take up the choline. And we see it pretty quickly. So the nice thing is we're able to start imaging very quickly. We don't have a long uptake time to be able to identify where there's disease. I'm now going to switch to fluciclovine or Axemin, which is probably around the nation the most commonly used agent at this moment. It was developed up at Emory University, where Dr. Pack and myself worked for a little bit of time. And what this is it's a different mechanism, but overall it behaves very similarly in terms of its sensitivity and specificity for prostate cancer compared to choline. So what it is, it's a non-native amino acid, a precursor of proteins. And what happens is these go into the cells, and because prostate cancers are dividing rapidly, they need to take in a lot of these amino acids for growth and protein development. And so it's a fairly good agent to be able to identify where there is biochemical recurrent in lymph nodes or other tissues. This is a case of a man that we looked at that had, again, definitive evaluation or treatment rather, and then low-level PSA of only 1 nanogram/ml, but short doubling time, and we're able to identify a single lymph node that I'm showing with my cursor. Hopefully you can see that. And that when it was resected, it dropped back down to a nadir. So these are both good agents to be able to identify disease. There are some caveats with that. Both of these agents aren't great for local disease. So when patients still have the prostate intact, whether they've had external beam radiation therapy or maybe brachytherapy, they'll still have a prostate. And we know that there's a lot of false positives that we get with the prostate gland itself. You can have things like prostatitis or benign prostate hyperplasia. They can look somewhat similar to prostate cancer. And basically, whenever I see something and when I'm looking for recurrent disease and patients that still have the prostate gland, I'll recommend getting an MRI to evaluate that, because that's really still the best modality. Alternatively, what I like doing here at Mayo Clinic is using our PET MRI, and that way we can get a definitive evaluation with the MR component as well as the metabolic agent with our choline. This is a simple kind of cartoon I put together to kind of show and to walk through what a patient would expect when you have these studies. Both choline and fluciclovine, I'm putting them up there together because even though they behave differently in terms of how the imaging takes place and what a patient would experience are very similar. We encourage patients to not eat for a few hours beforehand. Neither of these are that important. There's another radiopharmaceutical that we use for other cancers called fluorodeoxyglucose, or FDG. And that one you have to not eat for 4 hours because it's a glucose moiety. But these is not, we encourage it, but it's not really too critical. We get patients in, we get them on the CT or the PET CT scanner, and we do a quick scan to kind of get the computer to recognize where the body is. And then while the patients are still on the table, we inject the radiopharmaceutical. and then we start the timer. And then about 3 minutes afterwards, we start our PET imaging and right at the pelvis. And these times are a little bit lower now. We're actually down to about 2.5 minutes per bed position. So she can get through the whole scan in under 20 minutes. And this is, again, these are pretty good radiopharmaceuticals for both nodal disease, bony disease, and extra organ disease. A caveat is if you still have the prostate, they have a pretty good sensitivity, but the specificity, meaning able to rule out other benign changes, is a little bit lower. So we'd want to get the MRI on that. I'm now going to turn most of the time for the rest of the talk over that I have to PSMA, or prostate-specific membrane antigen. So this is a protein that people have actually looked at for probably a few decades. It's going on quite a while, but we're just now recent at the point where we have some agents to really take advantage of it. So this is a metallopeptidase. Doesn't really matter what it does, but it's overexpressed in high levels in prostate cancer. Other cancers as well, as like glioblastoma, will excrete it in their neovasculature, but for this purpose, we're going to talk about prostate cancer. So what it is this protein, it spans the membrane of these prostate cancer cells. And pretty much in almost all prostate cancers, a notable exception is neuroendocrine tumors, they overexpress it. So we're able to take advantage of this and design agents that target this specifically for both imaging and then therapy. So what these are right now, the current generation, if you will, of these PSMA agents, these are kind of small urea-based pharmaceuticals. So I have some cartoons or schematics of different agents here. And the moieties in red are kind of these commonalities between all the agents. It's actually a very simple urea substrate. I did my PhD in organic chemistry, so I could get all excited about that, but I'm not going to. But overall, this is the port that points to it. Everything else in this black that you see at these different agents, these are linkers, these are side chains that help kind of define that kind of flavor of the PSMA. It's kind of like if someone asked me, well, what's the difference between them all? It's very similar to, like, if I go grocery shopping for my family and they want vanilla ice cream, I can get French vanilla, vanilla bean, home turns. They're all different, but they all basically do the same thing. And that's very similar with these. Right now, there are 2 agents that have recently become FDA approved in the last year. This first one, PSMA 11, it's actually the gallium agent of it for PET gallium PSMA 11. Was initially received an NDA, or for FDA approval, if you will, from the California systems. And this is starting to be rolled out more across the nation. Another one that just within the last month, this DCF-PYL became approved. And right now, I would say, we're at this point where there'll probably be some others that are coming up with approval. We're still waiting for CMS reimbursement across the nation. There are some areas, like out in California, and again, this is kind of the nuance, getting into the details of stuff like, can I just go out and get this? Well, it depends on where you live. It depends on the institution you're at. If you're on the West Coast with their local Medicare group, you're able to get these approved and they'll get paid for. Here where we're at, it's a matter of time, but we're hoping that there's going to be not just this FDA approval, which we have, but also reimbursement, hopefully by the end of this year, if not earlier, which means that you can get this done outside of a clinical trial. Because right now, most places still in the nation, including Mayo Clinic, if you want to get a PSMA study paid for, you're probably going to have to either be paying out of pocket or part of a research study. And that's unfortunately kind of where we're at in this middle ground. But 6 months, a year from now, we'll be in a very different situation. But why do we do these? These are the same reasons that we do the choline and fluciclovine. We basically want to see where there's disease. And also we want to identify if these patients will be potential candidates for PSMA therapy, which we'll be talking about in just a minute. But as you can see in this patient, you probably are like looking, I'm like, I don't understand what I'm looking at. You have some salivary gland uptake, liver, spleen, some kidneys, but these dots right here on the right, these are these lymph nodes we're worried about. This person here has some disease along a rib, some hilar activity, some retroperitoneal nodes, and this person has a lot of disease in the bones. These are just different patients, and actually a little bit of they're not all the same tracers, but they show a little bit how this is a nice agent because there's a really high sensitivity for disease, and there's really not that much competing uptake in the normal body. There are differences, like I was saying before, between these different agents. So I showed you the slide, and there's like 10, and there's probably even more than that companies looking at getting into this market. And are there differences? Yes. Some of them will have more salivary gland activities. Some of them will have more urinary excretion. Ultimately, for the patient, I would not worry about whether you get a PSMA 11, where you get a DCF-PSYL and INT. They're all going to be very similar, and they're going to give you the similar results. Ultimately, who's going to be the biggest player? That's going to be the market that's going to decide. But there's not really like a clear winner as to like this one's the best. And again, I'm not being paid by any of these companies, so it's just kind of my 2 cents overall looking at the data. When we compare these studies, these PSMA agents, to things like choline and fluciclovine, they are better, especially with low PSA levels, meaning when you have just a little bit of disease, like a single lymph node or a single focus in a bone or something like that. You'll probably find it better with PSMA than either fluciclovine or choline. This is a study that compared those, and this is kind of what I'm saying. That being said, and I've talked to patients about this, they say, well, hey, look, I only have an ability to get a fluciclovine or this Axman study. I can't get PSMA. What do? Do I need to go pay for it? And that's when you start having a conversation with your doctors and the people treating you, because ultimately, these fluciclovine cholines are good studies. They do detect disease. And if someone has a relatively high PSA, good doubling time, you're probably going to see the disease. But the question is, for these single lesions, we'll be able to detect it. Maybe PSA is better. But that's not why really PSMA is exciting. Why PSMA is exciting is that we can actually take the same diagnostic agent and switch out a radiopharmaceutical, switch out the radioisotope and be able to change it from a diagnostic agent to a therapeutic agent. So this person had a PSMA PET with gallium here on slide A, and this is just showing you different images. This is a SPECT I was telling you about with the lutetium-177. And this is the therapeutic PSMA, and this is where everybody's excited about it, because now finally with prostate cancer, we truly have a way that if we can see it, we can kill it. So let's talk about what lutetium-177 is. This is an isotope. It emits a beta emitter. So Dr. Tzou was talking about photons and there's proton therapy and these things like that. So this is a little different, but again, it's all related to a certain degree. Beta emitters are basically electrons that are being emitted from an atom. And as this goes through short tissue, it will kind of cause a bunch of free radicals and damage to DNA. So if I can deliver this selectively to tumor cells, it's a way for me to give selective radiation to the tumor cells without giving so much damage to the adjacent tissue. And that's kind of the big point of this is, again, it's a way to give selective radiation therapy to the tumors. They don't travel far. So if you have small lymph nodes, it's great because we can treat those lymph nodes, but we're not going to be giving a lot of radiation bulk to like normal tissues, normal muscles, bone that doesn't have disease. And so again, it's kind of it's a well-tolerated methodology to give radiation to the tumors. We can image these and confirm that we are having the radiation delivered to those areas, but it doesn't give as high as resolution as the PET study. I'm going to first talk about it, not first, I'm going to talk about a couple trials now that have come out that have been kind of very exciting. So the first one is this lutetium-177 PSMA 6117. This agent is the most well-studied of these beta-emitting PSMA agents, and they compared it to cabazitaxel. I don't speak very well these drug names, but this is a chemotherapy agent. I'm not going to get into exactly the mechanism of it, but the inclusion criteria here is that these patients on a PET study had PSMA positive disease. They did not have any negative PSMA studies, meaning that sometimes patients will have a heterogeneous makeup. They will have some lymph nodes that have PSMA positive, but then other lymph nodes didn't light up until you see it with like FDG or an Axman study. And those actually imply a worse prognosis, that the PSMA therapy, unless it's hitting everything, the patients aren't going to do as well. So in this case, they clarified it to say we're only going to be imaging patients that only had PSMA disease. And what they found is that these patients compared to cabazitaxel had a better outcome and lower adverse effects. And so this is showing a chart, this is kind of a waterfall chart. And ultimately, what we want to take away from this is that this is kind of our comparative standard of care patients. The blue means that they did not really reduce substantially from their baseline levels. They didn't really respond. The red means that they did respond. And if we compare the cabazitaxel to the lutetium PSMA, we see that a larger percentage of patients actually had a favorable outcome in terms of their PSA uptake. And then when we look at the evidence of progression disease survival, how long they're able to live without evidence that disease is recurrence, we see that the lutetium PSMA did substantially better than the traditional chemotherapeutic agent. And so that was a study that came out a little bit ago. The most recent one that we have is the VISION trial, and this one is probably the one that generated the biggest interest. So this was compared to the best standard of care, and that included hormonal therapy as well as taxane therapy. And they looked at a large number of patients, 814 patients. And then what they found is that actually for both overall survivability and progression-free survivability, that there was an improvement compared to the standard of care. And there is enough, and you look at this, you go, well, wait, 15 months to 11 months, is that really big? Well, you know, it's not curative, but it's a substantial improvement. When we talk about chemotherapy now, there's already been so much work that's been done over the last decades that even this little bit of a difference is actually substantial and very exciting. And it's likely that we will be getting approval for this agent at some point in 2021 or maybe early 2022. Again, that's just my belief. I don't have any inside knowledge about it, but there is a lot of interest and the expectation that this will be approved. But we will wait and see. Again, at this point, there are no PSMA therapy agents that are yet approved. I'm just showing here a picture, and this is with actinium, which is an alpha agent. And I realize that this is not exactly beta, but the point is that what you see here in this patient A is what they had beforehand. Then we treated them, and you can see it basically goes away. Same thing, another patient, extensive disease. They treat them with the agent, it goes away. Now, this is again where I tell people radiographic response is not true response, because if it was, these patients would never have cancer, but we know that eventually they will come back. But the overall, the point is that they will live longer without either radiographic evidence of disease, and they overall will live longer with overall survivability. There's still questions that remain about the therapy, how much dosimetry, which is meaning how much can we give them versus like a fixed dose for everybody. That still has to be worked out. Can we combine therapies? Can we combine immunotherapy, radiation sensitizers, hormonal therapies with the PSMA therapy? How do we sequence these two ideals? So, and then alpha therapy. So even though we are probably going to have FDA approval for these agents, there's still a lot of work to know how we're going to optimize these for patients. And it is likely that whatever people are going to be doing in 2022 is going to be different from what people are doing in 2025 or 2030. I'm going to stop here for the sake of time. And again, I'll be happy to take questions at the end of the question and answer session.
Thank you, Dr. Parent, for sharing with us the innovation in imaging and the indications for the different imaging tool for prostate cancer. Excellent. We would like to proceed to discuss with us the options for metastatic prostate cancer. Dr. Makeyev will share with us those options and give us practical insights on how a medical oncologist see a prostate cancer patient.
Hi, thank you, everybody. I want to thank all the participants and panelists for inviting me. There's 29 participants, and I would like to talk without the slides, but probably the way I would I would normally talk to a medical oncology patient. So the role of the medical oncology comes later in the disease process traditionally, but it's probably not the best way to approach. I try to get early in the process of medical oncology care for the following reason, because previously described approaches such as surgery and radiation therapy deal more or less with the localized disease. So surgery deals with the prostate, the tumor inside the prostate, and it's a local disease, it's removed, and there's not much long-term systemic effect on the whole body. Same applies to radiation therapy. Radiation therapy pretty much removes something that cannot be removed surgically or shouldn't be removed surgically. Medical oncologist deals with the whole body. Unfortunately, in spite of best efforts of the surgeon and radiation oncologist, 1/3 of the patients will experience recurrence of the disease. What it means, a year, 2 years after localized treatment, surgery, radiation therapy, PSA will start to increase. And what it means that it's probably few, maybe few hundreds, maybe later millions residual prostate cancer cells are hiding somewhere in the body, and they pretty much starting to divide and springing back to action. So approximately 200 years ago, in English butchers noted that castrated bulls have shrinking shriveled prostate. And this fact was pretty well known, but no one really pursued it until a Canadian-American physician, Dr. Huggins, in 1930, decided to start experiments in patients with advanced metastatic prostate cancer. Based on this observation that male hormone has something to do with the prostate, he decided to perform surgical archaectomy or castration. So male testis is the main source of testosterone in the body. And by removing the testis, Dr. Huggins and his medical student, Dr. Hodges, were able to demonstrate that prostate cancer can be put in a remission, not a complete remission, but there was a clinical benefit demonstrated by declining level of the tumor marker called alkaline phosphatase. After a few weeks after castration, patients improved their appetite, their bone pain would go away, and that became a base for the systemic therapy. In the 1950s, chemotherapy was added to arsenal to treat other cancers, and it was not until 70s or 80s when metoxantrone and later docetaxel, those are two types of chemotherapy, were introduced in the practice. So, and again, to recap, the original model was pretty simple. If you're young and in good shape, you get a surgery. If you're not so young and in poor shape, you get radiation. Your cancer will come back 1/3 of the time, and then you go see medical oncologist to get your chemotherapy and with all the uncomfortable side effects associated with chemotherapy. It became much more productive nowadays and much more less troublesome. It's much easier to tolerate systemic therapy. I would just like to discuss different tools in our arsenal. So going back to Dr. Huggins, we do still work with the hormones. Starting with high-risk surgery, patients may receive adjuvant hormonal therapy. They may receive adjuvant hormonal therapy after radiation therapy. Actually, it's a little bit of a misnomer. You do not receive hormones. You actually deprive patient of male hormones by means of chemical castration, or sometimes we still perform orchiectomy, although not very commonly. In spite of that, PSA will go down after surgical or medical castration, but eventually within a year or 2 or 3, PSA will start to rise in 1/3 of the patient. And at that point, we are dealing with castration refractory prostate cancer. Or older name for this was hormone refractory prostate cancer. I actually like hormone refractory because what it implies that even though you don't have a testosterone on board anymore in a physiological levels, so your testosterone less than 50, but your PSA is still going up. So what it means, there's two possibilities: it either recurring or coming back locally at the area of prostate or pelvic lymph node, or it spread somewhere else. Somewhere else, 90% of the time will be the bones, spine, long bones, skull, and it doesn't spread most of the time to your organs, your visceral, liver, lungs, brain, but the bone is the main target. Recently, in the last few years, we realized that just depriving prostate cancer of the main source of testosterone is not enough. And we add medications called anti-androgen. What it means, it's usually a pill. Some of them earliest form of therapy was bicalutamide or Casodex. And what it does, it binds to a prostate to androgen receptor. Androgen receptor is a small molecule on the surface of the prostate cancer cell that gets signal from testosterone. So it's a prostate cell, there's a little antenna, androgen receptor, and we block this receptor or from internalizing, going inside the cell. And we accomplish it by giving patients pills such as abiraterone, enzalutamide, bicalutamide, apalutamide. Well, a lot of pills end with lutamide. And eventually this therapy will last, if you're lucky, for a year, maybe two, but majority of patients will become resistant to this form of therapy. And this is a recurring theme in any cancer. Cancer, unfortunately, mutates to kind of bypass your best effort. And so you have to be ready with plan B, with next line of therapy. Traditionally, chemotherapy was the only way to go after hormonal therapy, but in the recent 5-10 years, everything changed, and we have new modalities that we can add to our arsenal. So what happens when your Zytiga or abiraterone or enzalutamide stop to working? Your PSA starts to rise. You start noticing new spots of activity on PET scan or bone scan, maybe new symptoms, something starting to hurt. The patient go back to a medical oncologist, and we can do a lot. So the standard treatment at that point, we called it hormone refractory prostate cancer. That was docetaxel or chemotherapy. Chemotherapy is different from hormonal therapy. Chemotherapy is actually plant-derived chemical that come from the yew tree bark that prevents division of the cells. So the cancer cells have DNA or molecular code inside of it, and during the division, it uses small molecules to pull cells apart. Chemotherapy has ability to disrupt this process. And unfortunately, with this disruption of the cancer division, side effects come into play. Patients may experience lower level of white cells, red cells, fatigue, damage to nerve, loss of hair, nausea, and other multiple side effects. So in the recent years, additional modalities were introduced, such as radiotherapeutics, such as radium-223, which is alpha emitter. We didn't discuss it in details. I will defer it to my radiation colleague. But in a small subset of patients with prostate cancer, we can identify those who will respond to another modality called immunotherapy. Immunotherapy is an approach by which we allow your normal immune response to recognize cancer cells. So normally you may have some cancer cells present in your body, even if you're not diagnosed with cancer, but your immune system will be able to find these cells, attack them, and remove from the body by means of T cells, antibodies. Cancer cells have ability to use an escape mechanism. If you can imagine an umbrella that would allow cancer cells to hide from immune response. And we have several medications such as pembrolizumab that can remove this umbrella and allow your immune system to attack cancer cells again. Unfortunately, the number of prostate cancers that can be successfully treated with this pretty effective approach are very small, and it's limited to tumors that have evidence of so-called mismatch repair deficiency. So their immune makeup, their DNA structure is ineffective, and those cancers cannot repair DNA damage effectively, and they become kind of more open to your immune response. So this is a minority of tumors. Another approach in small number of prostate cancer, you can identify either acquired or inherited defects in DNA repair. So when your cell divides and it goes through the division cycle, it may accumulate genetic error, mistakes. So DNA did not line properly, and the cells have mechanism to repair it. Some mutation leading to cancer, such as BRCA1, very commonly found in prostate, in breast and ovarian cancer, will also cause DNA repair deficiency. And right now we have 2 drugs that are approved in prostate cancer for men who carry this mutation, BRCA gene, such as olaparib and rucaparib. So that's another approach. Actually, one of the first immune therapy was Sipuleucel T, which is a dendritic T cell vaccine with very interesting mechanism. You take your T cells, dendritic cells from the circulation. So patient sits in a chair, T cells get removed and dendritic cells from circulation, pretty much similar to bone marrow transplant. And those cells, they get exposed to the antigen, means part of the membrane of the prostate cancer cell. So they, to some extent, if you wish, they were educated and they're infused back into your body. That was the actually first immunotherapy in prostate cancer and many other cancers, introduced more than 10 years, but it didn't pan out to be a miracle drug, but it was shown to extend survival. So that's the name of the game, try to extend survival of the patient without compromising quality of life. And that's where the role of medical oncologists become very important, because all of these drugs, hormonal, chemotherapy, PARP inhibitors, radionuclide, immunotherapy, they have variety of different side effects. And medical oncologists have better understanding of side effects by the nature of the training. Medical oncologist is an internist who is trained to treat cancers in postgraduate period and the additional 3 years of training. And medical oncologists have better understanding about side effects. Let's say abiraterone may be more toxic for people who have heart disease due to electrolyte and disruption. For enzalutamide may lead to fatigue, and let's say patient on enzalutamide presents to me and complains of fatigue, I would not immediately attribute it just to the drug. I will rule out, I will try to exclude other causes of fatigue, such as thyroid insufficiency, maybe patients just simply anemic due to radiation proctitis that leads to constant blood loss. I will treat his anemia, and that's overall. Basically, I like to think about medical oncologist as a primary care doctor for cancer patient. Another important approach is a bone-targeted therapy. There's denosumab and zoledronic acid. It's 2 important tools in maintaining health of the bones for the patients who don't have metastatic disease. Neither of those drugs prevent development of the metastasis, but what they do, they preserve bone mineral density, because during the hormonal deprivation, you lose your testosterone, and testosterone is absolutely necessary for maintaining bone mineral density and muscle mass. So I frequently put my patients who don't have metastatic disease, who are still working with radiation oncologist or urologist on medication called denosumab, just to prevent development of osteoporosis. I advise them to start weight-bearing exercise to build up their muscles for further treatment. And we work about balance. I recommend yoga to preserve the ability to balance yourself, because it's a known side effect. Patients on androgen deprivation therapy, anti-androgen, frequently experience falls, especially older individuals. They become more prone to muscle loss and become clumsy, so you have to prepare yourself for that. Other side effects also possible, abnormal cholesterol profile and thyroid abnormalities, and these need to be addressed. So that's pretty much broad overview. When I meet the patient for the first time, we try to determine whether they stand in the course of treatment. Are they still hormone sensitive, or they're not hormone sensitive? So if your testosterone level less than 50 and PSA is climbing up, it's a definition of hormone insensitive, castrate refractory disease. There's not enough time to go through all the therapeutic options, but simple things that outlined. Bicalutamide probably not appropriate at this point. Sequencing, sometimes we do it, giving Zytiga after enzalutamide or other way around, but it's probably not the best approach. You have to think about different modalities. All the patients who have bone metastasis obviously have to be on denosumab, which is a bone targeting agent, which either preserves your bone mineral density or delays fractures. And at any point, if disease is not progressing rapidly, I would try to introduce Sipuleucel T, which is a immunotherapy. And later in the therapy, when we start thinking about switching to chemotherapy, Taxotere or cabazitaxel, I will definitely look for additional target. So we'll do molecular profiling. Molecular profiling, it's a new approach. Tumor tissue is screened for multiple genetic mutation that can be targeted, sometimes with the either clinical trial or immunotherapy. And I would just refer somebody to Dr. Ten in Mayo with not a prostate cancer, but with the mutation, with the tumor that will, patient who will go in a clinical trial. So that's basically broad overview of the role of the medical oncologist in treatment of the patient with advanced prostate cancer. And if you have any specific questions, I will be happy to address it now. And thank you again, and I wish you great health. All right.
Thank you, Dr. Makeyev. We are delighted to hear that there are certainly multiple options for patients with metastatic disease. There is hope, and even better hope. With that being said, let's turn over to the next session and ask Michelle Walsh to share with us patient assistance programs and caring for the patient and the caregiver. Ms. Walsh.
Thank you, Dr. Tan. My name is Michelle Walsh. I'm one of the oncology social workers at Mayo Clinic. And I just wanted to thank Dr. Tan and all the panelists for inviting me tonight to just briefly review our role and the role that the social worker can have as patients go through treatment and the support that we can kind of provide to patients, caregivers, their families. So it kind of extends out. So we really are patient advocates and liaisons as patients go through treatment during and after treatment. We work with the medical team, we work very closely with them, and many patients have different concerns in the beginning when they first start treatment and as they continue to go through treatment and even after treatment. So we're there to provide support, the emotional support. And then, as Dr. Tan, and we've been listening to all of our physicians speaking tonight, the medical team is really focused on making sure that our patients are getting the right treatment, that the side effects are being managed, and that, they're really tending to the medical side of things. Social work kind of looks at the bigger picture because there could be other concerns when someone receives a diagnosis of cancer. And those can include, questions regarding work. Usually that's the first thing that patients are concerned about, and insurance, and what is this going to cost at the end, and how are we going to afford this? How is my insurance going to look? So that's usually the first question that patients have. And so we will help with just basically understanding and navigating insurance and copays and understanding COBRA benefit, the disability, and applying for disability, Social Security. Patients have questions regarding Medicare and their Medicare supplement programs, and of course, Medicare Part D and the cost of all of these medications. So that's something that social work can assist with. The other component that we kind of help with are concrete needs. And these are, barriers that can come up, and we try to remove those barriers and assist patients in finding ways to assist with medical expenses, non-medical expenses. This could be transportation, housing during treatment. Many of our patients travel for treatments, and they might be here, receiving radiation treatment for several days. And so, we're looking to find what housing works for them, and affordable housing, assistance with transportation, and all of those kind of expenses as people are receiving treatment. The other piece is the medical expenses of this, like I had talked about, prescription coverage, and many questions usually as we're going into October and open enrollment starts, many patients have questions regarding that. And what are the programs that can assist with paying for some of these? And I'll briefly go through that tonight. I actually have a quick slide presentation, and I'll just go through that quickly with you as to, what resources are out there. Then there's also things that can happen at home, and that's the other piece of things as we're listening to some of the side effects of some of these treatments. Some things can be really difficult, can get a little bit more difficult and challenging at home. So what are those resources? What are the resources that the medical team can assist with, like home health care and other, assistance regarding medical needs, but then also just challenges of basic maintaining of the house. And many of our patients, sometimes that's really challenging for them. So looking into the community in which they're residing, and finding some of that support throughout the community. So those are all things that we help with. The emotional support, as Dr. Tan said, this can be very, very challenging. And so just kind of navigating and helping with, caregivers, patients, the challenges that they're facing as they're, continuing treatment. And so we are all licensed clinical social workers that can support patients and provide that counseling, and even find additional supports. And that could be, one-on-one support from another patient who's gone through something similar. It could be another caregiver that we're looking for, that companionship and that support from another caregiver who's gone through something similar. And then we also try to find support groups within your area. Many of them with COVID have gone Zoom. So it's very easy. I have patients, that join our support groups, and they're from all over the world. So that is an option now that many of our support groups for caregivers and for patients with prostate cancer can attend via Zoom. And it's much more convenient, I feel. We may decide that that's the way we want to do some of our support groups now, is via Zoom. So, and then, the other piece of things is, we help with advanced care planning, and that could be assisting patients with just paperwork documentation for HIPAA, or designating a healthcare surrogate just in the event that something during treatment that you were unable to make a medical decision, who would make those. So we would help with patients to understanding those documents, and then also assisting patients with completing them. So that's kind of a little bit of what we do, how you would get with a social worker. So one is that, patients can just request a consult with a social worker. That's always available. The second way is sometimes a physician will notice that there's some concern there and send a referral to us. And sometimes we'll send out screens too, just to check in with patients to see how they're doing. Now, many of the bigger facilities have social workers on staff and are embedded in the oncology team, but some cancer centers may not have an oncology social worker available in your clinic. So I want to let you guys know that there is support there, and Cancer Care actually has licensed clinical social workers on staff. They will help in all of the things that I discussed tonight. They would assist with in identifying resources and also providing that one-on-one counseling to patients and their caregivers, and it's all free through Cancer Care. So Cancer Care has some blogs too for patients and caregivers. So just being careful and mindful of which blogs we go on. I always tell patients you want to make sure that that's monitored by the appropriate facilitator with some kind of backing in that. As well as the support groups too. A lot of information that's shared, we want to make sure that that's valid and legit information. So just reminding you of all the support that's out there. So tonight, I just want to, the interest of time, I'm going to just briefly go through this. Let me share my screen here. Oops. Okay. So just kind of some assistance, and I'm just focusing more on the financial at this time, some assistance. There's some Medicare savings programs, Medicare Extra Help. That's also an option depending on your income level. And also Medicare savings program is done on an income level as well as some assets too. The manufacturers, sometimes there's assistance through drug manufacturers, and also some copay assistance through some foundations, and these are nonprofit organizations. These are all things that can help. And again, today it's just basically focused on the medical expenses. There's a whole bunch out there for non-medical expenses too, if you're looking. So there is a Medicare savings program, and I'm not really going to get into it, but Amanda is going to send you my PowerPoint, so you can definitely look more on the assistance out there paying for Medicare insurance premiums, especially B and D, the drug coverage. And these programs help with deductibles, co-insurance, co-payments. And it's also, again, dependent on the income and assets. How do you apply? Usually it's through Department of Children and Families. If you're in a different state, I'm sure that you can contact your Medicare office and find out where you can apply for that. Medicare Extra Help, again, this is a program that is it's income based. So, it has a little bit lower of an income guideline, where an individual would be $19,000 or less, married would be $25,000. And then there's also limits on assets. So again, you can get this through Social Security Administration, and they would help with the cost of the Medicare Part D. So your premiums, your monthly premiums, plus they would assist with some of the copays for drugs, and those can go down dramatically. And we're talking $5, $8 for a prescription that would normally cost of a very high expense. And again, it's limited just because it's income based, so you'd have to qualify for that program. Some other assistance programs, that are out there are patient assistance foundations, copays. There are two programs here, the rxassist.com and needymeds.com. Those two programs will help you with finding drug manufacturers and their assistance programs. There's also goodrx.com. That was kind of a hidden treasure, and now everybody has gotten familiarized with that. When I bring it up during a session with a patient, when we talk about drug costs, and those you can usually just go in and put in your drug, the dosage, and it'll see if they can find it at a low cost. Now, the goodrx.com is more along the lines of drugs that you would pick up at your pharmacy under Medicare Part D. The Rx Assist and Needy Meds, that also, but they also are, we can find some assistance with some of the infusion medications as well. Oral chemos, those types of things. Rx Assist, just giving you a brief overview. This is a database that you can put in the drug, submit it, and it'll tell you what program is available, and it'll go through their guidelines. then there's also the copay assistance programs through nonprofit organizations. These are copay programs which provide financial assistance for out-of-pocket expenses. Again, these are all FDA-approved treatments, and it's more along the lines for copays, deductibles, and coinsurance. So the ones for prostate cancer, and again, I'm going to be sending this out, so you'll have them: Cancer Care, Patient Advocate Foundation, PAN Foundation, HealthWell, and Good Days. When you look at these programs, some of them are closed, and patients kind of get this, disappointed because they're closed, and they could be closed for a while. I encourage you to either if you feel like you're eligible and you look at the requirements, then this could be your, the income, and most of them are just looking at your income. They're not looking at assets. They're looking at what your monthly income is, what your insurance is, and your diagnosis. And some of these actually have a higher than you would think for income levels. So, just kind of monitor. There's some wait lists that you can put yourself on, and they'll notify you when these foundations open up. So I do have one open tonight, and I really wanted to share this with everyone because when these programs come open, I try to tell all the physicians and the nurses and our staff. So there's one open tonight through the Assistance Fund. And this program is going to be helping with copays, deductibles, coinsurance. It doesn't help with premiums. Some of them do help with premiums, but this one does not. It's very easy to apply. When I spoke with the representative tonight, they actually have one of the highest income levels at 700%. So it would be for a family of two. Again, they're not concerned about what's, in your savings and assets, or what kind of house you live in. They're just more concerned about your monthly income. And the monthly income for this one is, if you make for a couple, $121,940. So if you're under that, I would say go ahead and apply, because this could be really, really helpful with some of the expenses, even oral. So these are some of the medications that they're covering, and you would just apply online, or you could contact them, and they would do that. They might ask for some information from you, and all of that information is online on the Assistance Fund. So you're just prepared when you make that phone call. So those are just some of the programs that are out there. Again, I just focus this PowerPoint more on the financial piece of things for medical expenses. But there's definitely some financial resources out there through federal and manufacturer programs, nonprofit organizations, and the manufacturer. Now, I will tell you this, and just remember this, is that if you're over asset on some of these things, or over income, doesn't necessarily mean that's a hard stop and they're going to deny you. So that's just a little tidbit of information, because some of these manufacturers and nonprofit, just like the Assistance Fund that I just spoke about, these funds, if you're over asset or over income, what they would do is they may say to you, well, if you can show us or prove to us that you've spent 2 or 3% of your income, your yearly income, on medications, and they would give you a number, then after you show that, then we would approve you. So you could actually put an appeal in, and they would consider, especially if you've paid a certain amount. And so they are aware that even though you make a certain amount of money monthly, there could be a lot of expenses that are going out, and so they take all of that into consideration sometimes. So if you feel like you wouldn't qualify, you may still want to call, because there's usually some exceptions to that. So and with that, I'm going to end. Thank you, Dr. Tan, again, for inviting me. I think the role of the social worker is pretty important. When I'll stop sharing my screen, sorry. Depending on what's going on, and different things can happen during different times. And you may need different resources. And so we constantly are there, part of the team and ready to help. So again, thank you, Dr. Tan, and appreciate everybody being here tonight.
Thank you, Michelle, for giving us a lot of helpful information, strategies on how to navigate our journey with prostate cancer. And that is some important websites that you might want to list down that might help you, because costs and other challenges are real. And so I would encourage you to take note of those. With that being said, we will move on to the question and answer portion of our webinar. I'll read the questions and then our panelists can decide who will answer the questions, or I will call on our panelists to answer. Panelists, please go ahead and turn on your webcam so that our audience can see you. I'll start with the first question, and I'll start with some of the questions that have been sent to me online, but there are some questions that are already in the question and answer queue, so I will ask those questions. I think this is for Katherine, but please chime in if you have other input with regards to this. Can you comment about radiation cystitis in the bladder after external beam radiation, and maybe some of the strategies that have been helpful actually for you as far as treatment for those who develop radiation cystitis?
Yeah, so that is an excellent question. And oftentimes in the literature, which is where we get a lot of our numbers and trials and things like that, radiation cystitis is sometimes grouped together as all things like individual symptoms like frequency, urgency, blood in the urine. So that's called hemorrhagic cystitis. So I'm not sure if this person was specifically talking about hemorrhagic cystitis, but there are different levels and different manifestations of cystitis. And the answer to that question is hard just because in the literature, it's not always reported the same. What I usually quote my patients is about 10% or less long-term. In our own, so I actually did a post-op analysis. So this is in post-prostatectomy patients. Our risk of radiation cystitis was actually about 2% at 5 years. So quite low. I mean, it's a slightly lower dose when we do post-operative radiation as opposed to definitive radiation. So, that reflects some of that, but I think a conservative number would be 20%. A lot of the more recent studies have grouped together all urinary symptoms in terms of side effect reporting. So they'll say, grade 2 or higher side effects, which is really to most of us just means they needed some sort of intervention. Doesn't mean it was severe, doesn't mean that it lasted forever. But if at any point they required medication for any GU or urinary symptom, including cystitis, but could also include other things like urinary obstruction, incontinence, anything like that. The rates of that are about 11% in the most recent data. The older data using older radiation techniques for definitive radiation, so going back to like the 80s and 90s where we were doing that sort of fixed beam 3D conformal technique, was a little bit higher at about 20 to 30%. But that also, a lot of those studies also included grade 1 toxicities, which do not typically involve intervention. So I know I'm hedging a little bit, but it's just because it's not super clear in the data. But I typically quote my patients about 10% or less long-term.
Thank you for answering that question. Maybe a question for Dr. Pak. There's a patient who had completed proton beam radiation about 2018, had been on Lupron since 2018, and also for Dr. Makeyev. What are the common side effects that you see in patients who are on Lupron? And are there certain websites that you will recommend? And of course, your clinical strategy in monitoring toxicities from being on Lupron. Lupron is a drug that's given as an injection for patients with prostate cancer who have locally advanced or metastatic disease. Go ahead, Dr. Pak, and then we will ask Dr. Makeyev to chime in.
Sure. Thank you, Winston. So when patients are placed on androgen deprivation therapy, medications such as Lupron, commonly develop side effects like low libido, hot flashes, depression and fatigue. I think you kind of have to take the symptoms and take them case by case and determine what's important. Obviously, low libido would be more challenging to address because one of the treatments for low libido is to replace testosterone. In this situation, obviously we cannot do that. So our hands are tied. Obviously, with most patients who suffer from low libido, sometimes it's just a matter of counseling couples and adjusting their intimacy. And we can certainly help with erectile function, but that doesn't always tie in with libido. I'll defer to Dr. Makeyev regarding certain treatments we can offer for hot flashes, but I would say that if patients are bothered by hot flashes enough, we can certainly consider medication treatment to address those issues.
Yes, very good answer. Yes, it's a challenging topic because the presence of testosterone is so integral for male well-being. Then when you suppress the levels to castrate level, you have dramatic changes in more or less, some people more dramatic in cognitive ability, libido, cholesterol level, muscle mass, bone mass. So that's the same reason why people take testosterone when they don't have prostate cancer, to be stronger, to be more virile, to do more things than other men can do. So that's very challenging. So going back, cognitive, well, that's a tough one. So you try to learn functions that you never done before. So doing crosswords puzzles not gonna help you. Probably trying to learn something if you have energy, like completely new, taking dance lessons, doing yoga. Actually, the best treatment for fatigue that we know of is actually physical exercise. It's not methylphenidate, it's not Ritalin, it's not Adderall. It's not cholesterol. You see your internist, you get on atorvastatin to decrease cardiovascular mortality and morbidity. That also goes up with the androgen deprivation. Androgen means testosterone. And weight-bearing exercises, denosumab or Prolia for those who don't have metastasis. Hot flashes, challenging in women, and to some degree in men. It's more troublesome in women treated for breast cancer. So we start people on SNRI analogs like Effexor. We can try it in men. Gabapentin may help you to be less aware of your hot flashes, but unfortunately will be more tired. So it's a key, and you want to correct something that you can correct. Yeah, I'll check your ferritin. If your ferritin is low, we'll try to fix your anemia. If your zinc is low in very small number of people, I'll give you zinc sulfate supplements. So you try to fix any small thing that you can fix. You go case, but there's not universe. Obviously, cannot give the androgen back. You cannot give. You have to ask people, because some people probably go and buy supplements, and it's not a good idea.
Question for Dr. Tzou again is the difference between CyberKnife, Calypso, and what does Mayo use compared to the other institutions? Does IMRT have lesser sessions compared to the other types? Just trying to understand the different terms or machines that are being used for radiation.
Sure, absolutely. So for the question about Calypso, Calypso is actually not a treatment machine. It is a fiducial marker tracking system that is oftentimes used in conjunction with CyberKnife. It can also be used without CyberKnife, so it's really just a fiducial marker. They make their own markers and they have this tracking system. So not necessarily administers treatment, but is used to help monitor that image guidance I was telling you about. And then CyberKnife is a brand name of a type of linear accelerator that we use for treating stereotactic body radiotherapy in different areas of the body. It doesn't have to be the prostate, but it's really designed, you know how Dr. Pack talked about that robotic arm that moves around. It's basically a radiation linear accelerator on a robotic arm, and it's designed for more SBRT type treatments. What I use at Mayo Clinic for SBRT is it's called a variant true beam machine. So it's a standard linear accelerator, but we're able to achieve very good dose conformality and essentially equivalent treatment plans with that type of device. So that's what we use here. I'm trying to remember if there were any other questions. Oh, the SBRT versus IMRT. So SBRT is it's a subgroup under IMRT. It's still very focal. It's just a higher dose per day, but it's a similar technique. So IMRT is sort of this umbrella term, and SBRT is like underneath the umbrella. So it is a shorter course of IMRT compared to that standard fractionation, which is 8 to 9 weeks, or moderate hypofractionation, which is over 4 weeks. So the time frame is different. In terms of advantages or disadvantages, the cancer outcomes are very similar for the first 5 years or so. It's not until you start monitoring out to about 8 to 10 years where you start to see a slight, just a very slight, maybe 4 to 5% differential favoring SBRT over moderate or standard fractionation. But the caveat with that is, you know, we have 8 to 10 year follow-up published data on SBRT, but we have like 15, 20, 25 year follow-up data with IMRT with the standard fractionation. So it kind of depends more on what the patient's goal of care is and what they're putting more weight on, because I can't tell them I have 20 year follow-up data. It's sort of what Dr. Parent was talking about. You know, by the time we get 20 years out, we have something new that we're doing. So, and that's kind of the situation with this. But right now, at about 8 to 10 years, there's just a slight separation of the curves in terms of cancer control, favoring SBRT. But really, on the whole, they're very similar in terms of side effect profile and cancer outcome.
Thank you, Dr. Parent. So obviously, after surgery and after radiation, there's a subset of patients that will have recurrence, and it could be local and systemic. So how do you screen for those? And for the panel, treatment options after RT and surgical recurrence of the prostate cancer.
So this question is changing. So if you'd asked me 2 years ago, the upfront would have been, or even a year ago, the upfront would have been an MRI and maybe, you know, CT, but pretty much everyone do a prostate MRI and kind of go from there. Maybe a CT to look for enlarged lymph nodes upfront. Then once you had the definitive radiation therapy, surgery, you would have molecular imaging therapy. Not molecular imaging, not therapy, molecular imaging. That's changed recently. There have been new guidelines. The FDA approved fluciclovine Axemin for initial staging, and PSMA does a pretty good job for initial evaluation of the prostate gland. And there's data from Emory and other places that look at these for the initial staging, but it hadn't really been approved for that. So the question is it's a question of what can you do and what should you do? Those are two different questions, two different answers. What can you do? Definitely biochemical recurrent disease. Should you do it up front? There's evidence that says that there's utility to it. I think it's a discussion to have with urologists, your oncologist, and know that there is more and more data out there that shows an upfront evaluation, you're going to have better outcomes. But again, that's kind of in that nebulous area where it's not yet really approved for imaging.
Thank you. Other panelists would like to answer about recurrences and how they manage local recurrences and how they clinically look for those recurrences.
Sure, I can speak to the radiation side of things. So if a patient has had definitive radiation, Depending on their PSA velocity and what they're eligible for, like Dr. Parent alluded to, there are certain guidelines and things that insurance will or will not cover, and then what should be done. So if they're eligible for imaging, I tend to like to get our combined choline PET MR. It's sort of two birds with one stone. The MRI, my colleagues in MRI tell me it's more sensitive for detecting small local recurrences, and obviously, you know, better soft tissue delineation of the prostate, and to see if there's any, you know, with some of the diffusion weighted images and things, they get a better picture of if there's active disease. And then you've got the choline PET to, you know, confirm that, or even, you know, rule out or rule in distant metastatic disease. And then in terms of treatment options, so kind of like what Dr. Parent said, I was laughing when you were talking, because what I say now is vastly different than what I said 5 years ago. Historically, the answer was always, oh, you just have to go on hormone therapy indefinitely after radiation. It was like one of the driving home points of, for a young guy, they should get prostatectomy because that's their the only option after radiation if they fail is that. But that's not true anymore. And now with the two biggest options post definitive radiation that we typically will recommend is HDR brachytherapy, which is that non-permanent implant, you know, twice done, separated by 1 to 2 weeks with radioactive seeds. There's a lot of data to support that now. Cryotherapy has also been demonstrated to be helpful. Usually, you know, for both of these, they require a repeat biopsy to confirm recurrence, in addition to the imaging I mentioned earlier. And then there's also a growing body of data for something called salvage SBRT, similar to when I'm treating the whole gland, but with the, in this case, focally administering it to the nodule. I personally would like to see longer follow-up data with that. So it's definitely not nationally accepted, but there are institutions nationally that are doing that, typically at academic centers. So I have not initiated that at Mayo Clinic, but certainly offered in certain spots around the country. But those are the main post-radiation therapy to the prostate. Now, if they have recurrences in lymph nodes outside of a prior radiation field, or in an isolated bone or something like that, then we could be looking at additional definitive radiation therapy to those areas.
Yes, thank you, Winston. So from the surgical perspective, you know, obviously to offer treatment for recurrent prostate cancer, number one, as my colleagues have already mentioned, you want to determine if the cancer is still localized or if it's become distant or metastasized. That would be the number one determination. Obviously, for our salvage treatments for recurrence, if the person has received radiation as a first treatment option for their localized prostate cancer and has had recurrence, we call that a salvage prostatectomy, where we go in after radiation to remove the prostate. That could be quite a difficult operation. Not too many surgeons offer that type of operation, and not too many patients necessarily sign up for it because the side effect can be quite tremendous. And the biggest limiting factor is incontinence. It's simply for the fact that the tissue has been radiated. And oftentimes I explain to my patients the difference between operating on a radiated patient versus a non-radiated patient. It's very much similar to trying to read a magazine that somebody spilled coffee on a week ago and the pages are stuck together. The anatomic layers and planes between the tissue are very difficult to separate, sometimes to the point where we have to literally carve the prostate out using cautery and dissection, as opposed to following a person's normal tissue planes. So by virtue of that difficulty in the surgery, that can create significant incontinence issues. Typically, incontinence with a prostatectomy is somewhere in the order of less than 5% for most patients. You know, with a salvage prostatectomy, the incontinence rate can be as high as 40%. So when you present to the patients, yes, we could potentially offer you surgery as a salvage treatment, a lot of patients will kind of self-select outside of that option because of the high incontinence rate and impact on quality of life. As urologists, we can offer other salvage treatments, such as those as cryosurgery, which falls into the ablation category because that's non-surgical. You're not removing, but you're, again, applying energy to the prostate to destroy the prostate tissue and cancer that's recurred. The interesting thing nowadays, as the paradigm is changing, is what do you do with cancer that's gone into the lymph nodes in the region, or even distantly? And the concept of oligometastatic disease and the role of surgery is quite controversial. We are doing them. We have clinical trials, but we are doing them actively at Mayo Clinic, and we offer them on a case-selected basis based on many factors. Most importantly, patients' desire to proceed with such treatments, but we heavily counsel the patients that is currently not the standard of care, because as Dr. Tzou mentioned, we're still trying to understand the landscape, and it does take at least 5 to 10 years to show effectiveness of what we're offering. And so we're just starting to see some early data for some of these salvage surgical treatments like pelvic lymphadenectomy for PET scan detected metastatic disease. And currently it doesn't look very promising, but in selected patients, it seems like a reasonable approach. Thank you.
Thank you, Dr. Makeyev. There's a question from
Yes.
the audience about hormone treatment and basically types of hormone treatment. I think you briefly mentioned about effects of hormone treatment on the body, but maybe you can elaborate its effect on the disease process.
All right.
Like the different brands and the different
Yes, absolutely.
doses
So,
and things.
yeah, so basic most primary androgen deprivation is obviously castration or castectomy, removing testes, followed by then it's a chemical castration. Chemical castration can be achieved by many ways. The most traditional was medications called GnRH, gonadotropin releasing hormone agonists such as leuprolide. It's once a month, once every 3 months, once every 6 months injection of the hormone that maintains a steady rate. So when hormones don't fluctuate up and down your levels in the blood, testosterone production decreases. Alternatively, the newer drug, Digarelix, it's GnRH antagonist. Once again, it just suppresses the level of this hormone. Recently, we got new drug called Rogorolix. It's a chemical way to suppress testosterone production. Basically, it's a pill. And you take it, testosterone goes to less than 50. So that's way you get rid of testosterone. But it's not enough. Testosterone, low level of testosterone is not enough. You still have receptors on cancer cells. And cancer cells, in a vicious way can produce their own testosterone or activate their own receptor. And that's where you need enzalutamide, abiraterone, so your Zytiga, Xtandi, or newer drugs that we don't use in metastatic disease yet, but they will be soon used. Daralutamide, apalutamide. So that's in regard to testosterone. There's some methods we don't use anymore. We used to give true hormones, estrogens. We used to take female hormones and give it to men. That's what Dr. Huggins did in the 40s, and it does treat prostate cancer to a degree. It decreases activity of prostate cancer cells, but we do not use it anymore due to side effects, and we have better treatments. All right, so that's regarding hormonal treatment. I think that's pretty much it.
Dr. Tan, we can't hear you. You're muted.
Sorry. Michelle, we know that patients with prostate cancer have challenges as far as their well-being. A lot of them are depressed. And could you share with us your distress screening at the clinic as far as patients with prostate cancer?
Sure, Dr. Tan. So when we send out a screen, it usually goes at Mayo Clinic. It'll go on the patient portal. And you'll just simply get a message that you have a screen to complete. And basically what we do is a psychosocial screen. And that could be, how are patients dealing with their diagnosis, how they're coping. Depression, anxiety, what we call anxiety, the anxiety related to an upcoming scan or a new treatment. So many times patients are experiencing that, and sometimes don't know where to turn to. They will sometimes turn with their physician, but then they're limited as to how, in depth we can kind of get. So that's where the social worker kind of comes in and asks those questions. How are you doing? Are you having some of, a lot of times it's affecting their activities of daily living. Fatigue causes, can really cause some depression. And we kind of help patients to work through those and come up with some interventions to help them. And so our distress screen, does involve some of the concrete, but it also involves a lot of how patients are dealing with that. And sometimes counseling is just kind of processing with social workers and just kind of discussing some of the concerns that they have. And sometimes that's helpful. And if it's determined that there's additional, some of these treatments are, say the least, are very invasive and can really cause significant side effects. And so with that being said, a lot of our patients are needing some additional support and some additional therapy. And we're just not talking about talk therapy. Sometimes what we use is what we call accelerated resolution therapy. It's when patients are experiencing some deep depression or some, very high anxiety. And it's really making an impact, and it's having a severe effect on their relationships and their ability to enjoy anything that they used to enjoy. So sometimes we'll use that therapy in addition to talk therapy. Sometimes there's some, understandably, some post-traumatic stress too that comes from some of this. And so we have some psychotherapies that we will do with patients, and also refer to our psychologist, Dr. Ames, too. So we have a lot of services and support for our patients and caregivers. And again, when I'm talking all about patients, we also have a question and concerns about if you're caring for a loved one, or there's questions and concerns for the caregiver. So that's all included on our distress screen.
Thank you very much, Michelle. I'd like to remind you that the care of the prostate cancer patient is a teamwork, and above all, they need long-term follow-up. And that reminds me to remind all of our patients and caregiver of the importance of survivorship. Cancer survivorship is a program of every bona fide cancer center. And we do have one which would address some of the long-term challenges with patients with prostate cancer. One last question that we did not answer. It's regarding radiation-induced cancers that one of our patients is asking about.
So the data that we have for that is usually extrapolated from other disease sites and or natural disasters, unfortunately, either man-made caused or natural. But typically the risk of a secondary cancer developing either in the prostate area, usually it would be a secondary cancer would be considered anything in the radiation field. So it'd be bladder, rectum, soft tissue or bone, like the muscles and bone around there, or even the prostate itself. Anything that develops after radiation is attributed to the radiation in any study. The risk of that is typically less than 1% per year cumulative over the national average, starting about 15 to 20 years after they complete radiation treatment. So the risk is low, but it's certainly present and definitely something to consider in our younger patients, because over their lifetime, obviously they have a longer lifespan ahead of them than potentially our, much older patients.
Thank you. I think one attendee has a question. Karam, are you raising your hand? Karam, are you raising your hand? Or maybe you just put it by mistake. Our last presentation has been pre-recorded for this program. this unfortunately would not be shown due to technical issues. This would be in our website. It's regarding the challenges of quality care, pharmacy benefit managers, and advocacy at the level at Tallahassee for Florida and nationally in DC for cancer patients, funding for research, for support groups, and coming together to bring about changes, actually enhancement in the treatment of the prostate cancer patients. I would like to thank the panel for this engaging discussion and for their thoughts, for their ideas, and being very upfront in answering their questions. Thank you for your expertise. Thank you to all of you, and I wish you have a good night. Please turn off your webcams. For the attendees, I have a few things to remind you. Please be on for a few seconds. I hope this presentation was meaningful to all of you. Once again, we like to thank Blue Earth Diagnostics for sponsoring this webinar. And as a reminder, all the handouts mentioned in this webinar will be available to you. Amanda Bridges will be helping you and making the event online actually available at the Flasco website. This has been recorded, so if you miss anything and want to hear it again, it will be available at the Flasco website. I always say learning begins with each one, but 1,000 steps starts with one. And that step would be made by you sharing what you have learned today to others so that we can make a difference in somebody's life. Thank you very much. Thank you on behalf of Flasco, and have a good evening. Take care.